Hi there, my name is Shaqil Kassam. I'm a medical oncologist from the Stronach Regional Cancer Centre in Newmarket, just north of Toronto in Canada. And I'm going to give my take on what I've seen so far at ASCO 2026. We're into day 2 or day 3, I think now, and we just came out of the plenary, and I think by far the most dramatic data that was presented is in pancreatic cancer. The RASolute 302 trial, I think it is, which Daraxonrasib, which is a KRAS inhibitor, showed a remarkable efficacy in both OS, PFS, and response rates in pancreatic cancer that harbor the classic KRAS mutations, but also appear to be effective in patients with the non-classic KRAS mutations and those with no known KRAS mutation at all. It looks as though the overall survival in the second-line treated patient population was approximately a median survival of 13.2 months and compared to 6 months in the control arm. And the discussant, Dr. Knox, from Toronto as well, did also mention that perhaps there might be a developing tail on that curve, which is dramatic. So I think by far and away, this is standard of care in the second-line pancreatic cancer. I think a lot of discussions are going to have to happen with regards to access. I think staying in the GI space, the next most sort of remarkable data that was updated was the BREAKWATER study, which was the cohort 3. BREAKWATER, as many people will remember, is first-line BRAF V600E-mutated advanced colorectal cancer, which were RAS wild type. And the BREAKWATER initial publication was for FOLFOX as the backbone chemo, combined with cetuximab and encorafenib. Cohort 3 actually included patients who had FOLFIRI as their baseline chemo backbone, but again with encorafenib and cetuximab. And the data that was just presented showed the overall survival that was not reached from the median for the investigational arm or FOLFIRI, but the standard of care arm, which was FOLFIRI alone, had a median overall survival of 20 months. Overall, this is dramatic, and it looks as though FOLFIRI, which is generally thought to be better tolerated, may have as good or perhaps better efficacy compared to FOLFOX plus the same combination. Still to be determined as the data matures, but I think it's now clear that it's safe to use encorafenib, cetuximab with either FOLFOX and FOLFIRI. And I think the next and the last GI one that I'll just talk about is the challenge study. And I think this has been published, clearly it has been published before. It is a regimented exercise program for 3 years in the adjuvant treatment paradigm of patients with colorectal cancer. And in this study, patients got 3 years of a structured exercise program, and it showed a dramatic overall survival benefit. And today, the cost effectiveness was actually published, saying that, is this really a cost-effective strategy? And it clearly is. As you might recall, this was a randomized study to patients getting 3 years of exercise, facilitated through physical therapist, trainer as it were, versus just getting information about healthy living. Clearly, it costs money to have a personal trainer, for 3 years and having guided exercise. But we saw that compared to just handing patients information, there was really no increase in cost, even though there was about a $4,000 to $5,000 initial upfront cost. More dramatically though, equal drugs, oral IV drugs that showed similar OS benefit in Canada, and I think in general we use a metric called the ICER, and this study came in less than $50,000 per quality adjusted life year, whereas other drugs have a cost of greater than $500,000. I think the average was about $200,000 to $300,000. So clearly this is a cost-effective, easy to implement standard of care to be added to patients who have resected colorectal cancer. I think just briefly moving on to lung cancer, I think there has been some really interesting data. The Crown data just updated their updated PFS, and at 7 years, the median overall survival of patients who got first-line lorlatinib with ALK-positive metastatic lung cancer has not been reached. So this is telling us that the median PFS of patients is still not reached. And if you look at the curves from the last update to now, Crown 4 versus Crown 7, there's a very little decrease in the PFS curves. That does not even discuss the OS yet. So this is clearly cemented as the standard of care until there is something else that will take the crown, and we'll see. I think finally, the most interesting data that was just presented at the plenary was adjuvant selpercatinib in RET-mutated non-small cell lung cancer. These are patients who had resected disease, stage 1B to 3A, using the AJCC8, and these patients could have had chemotherapy, 90% of them did, and they were randomized to 3 years of selpercatinib versus standard of care, which is this observation. And there was a benefit in the event-free survival, which was just published and reported today. So clearly, I think there's a trend. We now know that EGFR-mutated lung cancer, ALK-positive lung cancer, and now RET-mutated lung cancer in the adjuvant setting benefit from adjuvant targeted therapy. More to come, because I think there's still 2 more days left of ASCO. Thank you.